I just want to begin by thanking all of our speakers and welcoming all of our participants in this session. And I'm going to begin with introducing the first two speakers of the four that we have here speaking with us today. I'm going to begin with Leah Graham. Leah graduated from Millersville University of Pennsylvania, where she graduated with a bachelor's degree in respiratory therapy. Since graduation, she has been a respiratory therapist at Nemours Alfred DuPont Hospital for Children. She has also been an active member of the Inpatient Cystic Fibrosis Task Force since its implementation in 2017. In 2019, Leah stepped into a new role of acute care, which was a clinical lead, which involves being the respiratory care lead for multiple specialized inpatient areas, including hematology, oncology, cystic fibrosis, and medically complex and limited stay units. Along with continuing to be an active inpatient RT, Leah also works very closely with the outpatient CFRT specialist. She orientates new staff to the units, and she also educates medical students and physician teams on respiratory topics and equipment. Leah has also organized many interdisciplinary CF education events. But in addition to being a registered respiratory therapist, she also holds the credential of neonatal pediatric specialist, and she's also a certified asthma educator. Leah was awarded the Respiratory Care Practitioner of the Year Award in 2018. And so welcome, Leah, and she is excited to be here talking with us today. And then our second speaker is Mary Jones Gannon. And Mary began her career as a respiratory therapist and then continued her career by obtaining a master's degree as a clinical nurse specialist. And she now works as an advanced practice nurse and the clinical coordinator for the Adult Cystic Fibrosis Center in Christiana, at the Christiana Care in Delaware. Mary has been at that CF Center coordinator for the past 18 years. The Care Center recently, within the last 4 years, obtained accreditation status with the Cystic Fibrosis Foundation. She has worked to develop a very successful transition process with the Nemours DuPont Pediatric Program in the state of Delaware and works closely with that team before and after patient transition. The Christiana Care Cystic Fibrosis Program, it now sits under the umbrella of the Center for Special Healthcare Needs. And through this program, primary and specialty care can be offered in one program for people who have pediatric onset chronic disease. They are able to now provide care of the whole patient, and it has been a great success. Mary is currently back in school to become a family nurse practitioner so that she can help to provide care and so that she can help provide this primary care to patients. And now I'm going to turn over the rest of the introductions of our last two speakers to Dawn Seelhorst to introduce the last two of our speakers.
So I'd like to introduce to you Kathleen Richards. The title of her presentation is Continuing to Bridge the Gap Between Outpatient and Inpatient Respiratory Care. A little bit about Kathleen. She has been a respiratory therapist since 1982. She has worked at Primary Children's Hospital in Salt Lake City, Utah since 1993. She's currently the supervisor of the Pulmonary Function Lab and has been a member of the CF multidisciplinary team there for over 25 years. She's participated in the IHC Advanced Training Program in Healthcare Delivery Improvement from September 2003 to January 2004 and has been a participant in many QI projects at Primary Children's Hospital. She has served as the respiratory therapist member of the Pediatric Multidisciplinary Benchmarking Team for the Cystic Fibrosis Foundation in 2006. She has also served as the facilitator for the CF Respiratory Therapy Mentoring Program on behalf of the CF Foundation from 2008 to 2012. She serves currently as the co-moderator of the USCF RT Specialty Group since its inception in 2013. She has served on various advisory boards and speakers bureaus. She served on the NACFC Program Planning Committee from 2016 to 2019. And at the NACFC conference in 2019, Kathleen was presented with the Mary M. Contos Care Champion Award for all of her contributions to the care of cystic fibrosis patients. Please join me in welcoming Kathleen. Our next speaker is Perdita Shook. Perdita's, the title of her presentation is Bridging the Gap Between Knowledge and Action. Perdita currently works at Cook Children's Medical Center in Fort Worth, Texas. She serves as the inpatient CF respiratory therapist, and her job is to ensure that the patient's respiratory care while hospitalized is delivered per the physician's orders and to the standards of the CF Foundation. She educates both staff and patients in current CF practices relating to respiratory care. Her experience encompasses neonates to geriatrics, long-term facilities, and intensive care units. She's also worked in home health and a sleep lab, giving her a unique perspective to address the needs of the cystic fibrosis population. Perdita has been a respiratory therapist for 33 years. Please join me in welcoming Perdita.
Hello, my name is Leah Graham. I am a respiratory therapist and the acute care clinical lead for the respiratory care department at Nemours Alfred I. DuPont Hospital for Children in Wilmington, Delaware. My presentation today will be Bridging the Gap, Improving Inpatient CF Care. I have no relationships to disclose related to this presentation. In addition to the objectives in the discipline group description, I will also be discussing the impact of continuous improvement projects and also discussing the importance of interdisciplinary collaboration. So to give a little background, our facility is located along the East Coast in the state of Delaware. We are a 260 bed facility and the only level 1 pediatric trauma center in the state. We have multiple intensive care units, a critical and ECMO transport teams, and also a global outreach program. There are about 100 inpatient RTs within our department. They can work in over 10 different units, including the emergency department. And we also assist in a number of various roles, including assisting in bronchoscopies, assisting in the cardiac cath lab, cardiac OR, ECMO, as well as critical care transports. The CF Care Center sees about 100 CF patients outpatient per year, and we have approximately 40 to 50 CF patient admissions each year. So identifying problems. In 2013 and 2014, a needs assessment survey was collected with both inpatient CF patients and families. From the interview and surveys, multiple gaps in inpatient care were identified. We broke them down into 3 categories. So inappropriate infection prevention and control. This included inadequate PPE both in and outside the patient rooms. Associates from multiple disciplines not donning proper PPE while entering patient rooms, as well as RTs not properly labeling, cleaning, and discarding respiratory equipment as indicated. Improper use of airway clearance therapies included inappropriate settings for specific airway clearance devices, inappropriate orders, and incomplete documentation in the electronic medical record. And then finally, improper order of medications and therapies. RTs were performing the order of therapies outside of the recommended guidelines. These gaps led to patient and caregiver confusion and frustration, incorrect education, especially prior to discharge for patients, and an inconsistency of care. Patients and families both felt that as a new RT was caring for a CF patient, there was a new way of doing the order of therapy. So there was no consistency of care. One item to note from the 2013 and 2014 survey assessments was the sample size was relatively small. We only had 7 surveys during the 2013 and 2014 study. So exploring and implementing solutions. From the initial survey results, 2 major changes came about. The first was the initiation of CF family rounds or CF grand rounds. This was a multidisciplinary rounds that are held bi-weekly for inpatient CF patients. Members from both the outpatient and inpatient care teams are invited to participate, as well as the patient, family, and caregivers are also invited to participate as well. Members of the outpatient care team include physicians, APNs, the clinic RT, PT and OT, the CF care coordinator, social worker, pharmacist, and the inpatient care teams included the attending on service, fellows, residents, medical students, both the bedside RT and bedside RN, child life specialists, and other disciplines when appropriate, including endocrine, transplant, and palliative care. This was a time for everyone to get on the same page, make sure everyone is aware of any upcoming procedures and tests, and then also to help plan for discharges and to give patients and parents both ample time to ask and answer questions. The second change which came about, which will be majority of the remainder of this presentation, was the implementation of a CF respiratory task force, along with support from both the CF Center Director, Co-Director, and the Director and Respiratory Leadership. A CF task force was designed. The initial task force comprised of 14 registered respiratory therapists with representation from all shifts, day shift, night shift, and outpatient. The task force went live the first quarter of 2017. The RTs on the task force received more extensive education and training related to the CF disease process and also CF Foundation guidelines. The goals of the task force include serving as a clinical resource for both respiratory care staff, physicians, as well as other caregivers and patients and families, acting as a patient and family champion, acting as a bridge between inpatient and the outpatient care teams, as well as mentoring staff members, providing education, providing audits when necessary, and also being a bedside clinical care practitioner for CF patients. So the CF task force, the initial members of the task force created mandatory requirements, both to keep themselves as well as others accountable while they are on the task force. Some of the member requirements include monthly meeting attendance, whether in person or over the phone, attending a CF education day, which I'll talk about in a little bit in the upcoming slides, attending an outpatient clinic day with the clinic RT, as well as providing patient and family check-ins. When a CF patient is admitted, the CF families can expect to see a CF task force member within the first 24 hours of being admitted to the hospital, at least once a week while they are inpatient, and 24 hours prior to discharge. As well, the CF task force members also have to commit to a work group within the task force. There's 4 sub-work groups. The first is the journal club. They provide monthly journal articles and discussions during the task force meetings. The communication team provides information to both the task force and respiratory care department. This includes meeting minutes and newsletters to the department on important CF-related care items. The research task force submits IRB paperwork as well as performs research related to CF inpatient care. The education team is responsible for working with both the respiratory care department and nursing departments to plan education days. And then finally, the patient improvement work group is responsible for tracking inpatient CF data, as well as performing audits to ensure that RTs are providing the order of therapies correctly. Additionally, the patient improvement work group also provides tracking for task force members to ensure that everyone is meeting the task force requirements. Members in each work group take turns reporting out what their work group has done in the previous month during the monthly meetings as well. So some of the accomplishments so far from the CF task force includes creating and updating the CF reliable method, which I'll show in the upcoming slides, working and providing education days for new hires as well as RTs and nurses at other facilities, emergency department and inpatient admission checklist, and also improving communication among RTs. So the reliable method was created in conjunction with the CF care team, respiratory and nursing leadership, and input from the CF Family Advisory Council. The reliable method, along with an order of medication sheet and a photo composite of current CF task force members, is placed in the room upon admission. The reliable method has both a respiratory and nursing items listed on the method. It's a best practice information for both groups, and it is reviewed and initialed at least once a shift by both the respiratory therapist and the bedside nurse. Since creating the reliable method, this has helped with improving and standardizing care for CF patients while they are admitted. Last summer, the CF task force added additional information to the back of the reliable method. We added respiratory care equipment. It was created so that RTs have information about how to properly label, clean, disinfect, and discard respiratory equipment, specifically for the RTs who may not work with CF patients that often. During the yearly RT Skills Assessment Fair, RTs gave positive feedback on this new addition, as well as they listed some suggestions for additional items that may be added at a later date. Another bedside improvement created by the CF task force was the treatment plan card. This was created in 2018. Upon admission, the treatment plan card is placed in CF patient rooms where the respiratory equipment is stored when it's not in use. The treatment card is filled out either by the bedside RT or a member of the CF task force. On the screen is a generic example of how a card may be filled out for a patient. So the first column is the frequency of the therapies, the time the therapies are due, some common medications and treatments that CF patients may be ordered is listed in the third column. The fourth column is information regarding what can and cannot be performed simultaneously at our facility. And then the final columns were added as a visual to help see what medications can and can't be mixed together, or what medications can be done at the same time as an airway clearance device while a CF patient is admitted in the hospital. The addition of the treatment plan cards has helped improve consistency of care. RTs have given positive feedback on the treatment plan card. They say that it's especially helpful if they haven't worked with CF patients in a long time. And then as well, new hires and RT students have also given positive feedback. They say that it helps as a visual between the clinical and classroom. So the CF task force has also helped to push for more education regarding cystic fibrosis for both our associates and RTs at other facilities. Within our facility, new hires now have clinic time with both the outpatient RT. Their orientation, during orientation to the specific CF unit, they are paired with either the clinical lead for that unit or with a CF task force member. And then they are also provided extra time to review CF care standards. And there's also a resource binder that is updated in the RT workroom on that unit. The education work group for the task force is responsible for organizing RT and RN education days. The education days are typically held in the spring and the fall, although the spring education day had to be canceled due to COVID. And the fall education day, we are currently working on making virtual this year. The education days itself, we have speakers from the CF care team, as well as a member of the CF Family Advisory Board or a CF family member. Some of the topics that are covered include overview of cystic fibrosis, airway clearance therapies, respiratory equipment and spirometry, CF exacerbations, nutrition and CFRD, psychosocial and cognitive approaches to care while inpatient, as well as facility-related practices and policies. Additionally, some of the other items that the education work group provides is a CF-related poster during Respiratory Care Week and a respiratory skills fair poster related to CF, as well as they help with a CF station at skills fair. So evaluating the outcome. In 2019, the research work group received IRB approval to perform a follow-up study to the initial assessment survey done in 2013 and 2014. The objective was to compare results pre and post implementation of the CF task force. The survey was started in 2019 and it's still ongoing until the end of this year. So far, we've had 14 surveys since the time of this presentation is being recorded. The chart on the right-hand side shows our progress so far. The darker blue is results from the initial survey, and the teal, lighter blue-green color is from the current survey that's ongoing. So we've had a 78% improvement in RTs performing the order of medications and therapies properly. We've had a 57% improvement in the airway clearance therapies. This included the appropriate device selection and appropriate settings for the airway clearance device. And we've had a 33% improvement in proper infection prevention and control. This not only includes having PPE at the bedside, but it also includes respiratory equipment being properly labeled, cleaned, disinfected, and discarded at appropriate times. So we've gotten closer to 100% in all the areas, but we still have room for improvements. We're hoping with the addition of the respiratory equipment on the back of the reliable method and also the treatment care cards that we will hopefully increase our infection prevention percentage over time, as well as the order of therapies. Additionally, the CF task force provides random audits, and they will provide in the moment corrections for RTs. So even with the creation of the CF task force, the number of RTs caring for a CF patient while admitted are still high. In 2017, after the respiratory task force was created, we began tracking both the length of stay for CF patients as well as the number of RTs that cared for each CF patient. One of the limitations with collecting this data is we don't have any information to compare with the 2013 and 2014 assessment. We only began collecting this data in 2017. The graph to the right is from an abstract that we submitted this year to NACFC, which I'll provide that information at the end of the slide. The data is from 2017 to 2019. It shows the overall length of stay for a CF patient is about 10 days, while the average number of RTs that cared for a CF patient is about 13. The 2020 data is still being collected, although it might be skewed due to COVID and a decrease in admissions this year. So our goal is to use this data to help implement changes and ideas that will hopefully decrease the number of RTs caring for CF patients while they're admitted. We're also hoping that this will in turn continue to help reduce miscommunication, as well as lead to an improvement in continuity of care, which will lead to an increase in both patient and family satisfaction. Another quality improvement project currently being worked on is a collaboration between physical therapy and the task force and respiratory care department to create daily schedules for our inpatient CF patients. We're hoping that this will help improve wake, sleep, and daily life while admitted, as well as avoid overcrowding and multiple disciplines trying to see a CF patient at one time. And then we're also hoping that this will allow free time for CF patients to help decrease stress related to hospital admissions and hospital stays. We're also hoping that by having the daily schedule, both physical therapy and occupational therapy will be able to time their interaction with the CF patients immediately following airway clearance therapies, so that the patient has maximum benefit and cooperation for their other therapies. Before I get to the conclusion, I just want to briefly say that although we've had great accomplishments so far with task force projects, it has taken a lot of work and rough drafts to get where we are today. We've had ideas that haven't worked at all. We've had bits and pieces of some ideas that we've used and created what we currently have created that I've talked about in this presentation. What has worked for our department may not work for other departments, as well as what may work for your department may not work best for our department. So in conclusion, although there's a lot of data on quality improvement and continuity of care, there is very little data on quality care for the inpatient side, especially inpatient respiratory care with CF patients. By collaborating and working with the respiratory care department, the CF task force has been able to make great improvements so far. The improvements wouldn't have been able to happen without the continued support of our CF center, director, co-director, the CF care team, respiratory leadership, and nursing leadership. And then just a final remark, bridging the gap is not always a quick jump like the first photo up top. Sometimes it's a much longer bridge than it looks like the bottom photo, but it's about making progress. And then I would just like to acknowledge and thank our CF care team, CF task force members, respiratory department and respiratory leadership, as well as our CF unit, both the nurses and nursing leadership. Please reach out if you have any questions. Our abstract related to the charts that were shown is e-poster number 108 if you would like to look at more information from that. Thank you for your time and enjoy the rest of NACFC. Hope to see you all next year.
Hello, my name is Mary Gant, and I am the nurse coordinator with the Adult Cystic Fibrosis Program at Christiana Care in Wilmington, Delaware. I'm going to talk to you today about coordinating care between the settings, specifically the inpatient and outpatient setting for those patients with cystic fibrosis. The objectives of this lecture will be to understand the importance of a cohorted unit for the inpatient care of those with cystic fibrosis, to explore the process of involving a multidisciplinary team for patient identification and safety, and to identify ways to foster communication between the two settings. I have no relationships to disclose related to this presentation. So what we were finding with our adults with cystic fibrosis is when they were admitted to the hospital, they could go to one of a number of units between two different facilities. We have a campus in Wilmington as well as a campus in Newark, Delaware. And we were finding that we were spending a lot of time educating staff on those units, how to take care of our patients with cystic fibrosis, only to have the next time a patient came into the hospital, they would go to a different unit and we'd have to start all over again. So we wanted to identify one unit where patients would go each and every time they were admitted, where we could spend the time educating the staff, as well as the respiratory therapy department, on the care of specifically patients with cystic fibrosis. That way, we wouldn't be spinning our wheels having to educate a different unit each time we had a patient admitted to the hospital. So the cohorting allows for education of staff as to the specifics of the care of a patient with cystic fibrosis, understanding their therapies, understanding why they're on the therapies they're on, and most importantly, the infection control measures for our patients with cystic fibrosis. We all know that the care of each and every person should be tailored to the individual, but in particular those of our patients with cystic fibrosis and those who have cystic fibrosis related diabetes, that care is so specifically different than other patients who have diabetes, as well as all of the other different care that patients with cystic fibrosis needs. So the staff on that unit would become very familiar with cystic fibrosis as well as our patients. And the patients with cystic fibrosis would also become familiar with the staff on the unit, thereby reducing anxiety for when people would have to be admitted to the hospital. It also enhances infection control procedures when the staff understand why they're doing what they're doing and that they know to do it each and every time they're taking care of a patient with cystic fibrosis. We also work to have consistency of respiratory therapy staff because we feel that this is equally important. Many hospitals don't have respiratory therapists that are designated to a specific unit all the time. They could potentially be assigned to a different unit on different shifts. But we try to work to establish a group of respiratory therapists that became more of specialists with our cystic fibrosis patients so that they would also be assigned to that unit that the patients were cohorted to. We also found that it was very important to work with infection control. As I stated, when our patients would go to different areas of the hospital, we were then spending time helping the staff to understand the infection control needs of our patients with cystic fibrosis. So we instituted a new infection control policy. Beginning May 24th of 2018, all patients with a cystic fibrosis diagnosis would receive an isolation code of XF in our Sorian system. Our Sorian is our patient registration system. And so I would submit to our infection control department a list of our patients so that if at any point in time any of our patients came in and were registered in our system, they would be shown to have that XF designation and everyone would know exactly the type of room that they needed and the type of infection control that needed to be followed. It would mean that they would not be cohorted, they would have a private room at all times, and the contact precautions would be at a level 1 in our facility, which is a purple sign on the door, so that everyone understood what the infection control guidelines were. Now, when this policy was instituted, visitors were not required to wear PPE. However, we all know that the world that we live in right now, everyone wears PPE. And visitors in the hospital, depending on the health system, can be very restricted if visitors are allowed at all because of the pandemic crisis that we're under right now. But when this all goes away again, and prior to this, visitors were not required to wear PPE because they weren't going in and out of different patients' rooms like our staff would be. We also worked to make sure that the outpatient and inpatient documentation was easy to obtain. Previous to this work, when someone would be looking for what the outpatient team's plan was for this patient with cystic fibrosis, they would have a lot of different clicks and they would have to look in many different places. As you're well aware, all of the cystic fibrosis teams are made up of at least 6 to 7 multidisciplinary team members. That would mean looking into the chart into that many different locations to find what the different plans were from the physician, the advanced practice nurse, or the nurse coordinator, the respiratory therapist, the physical therapist, the dietitian, palliative care, possibly a pharmacist who is working with the patient, and any other team members that may be working with the patient. All of that documentation was in different locations. It made it very difficult to put the pieces of the puzzle together. So we worked with our IT department to create a one-visit document for all of our disciplines. So now whenever we see a patient in the outpatient setting, all of the documentation from that visit goes into one note. So people on the inpatient side only need to access that one note to see all of the different disciplines that have interacted with that patient at that visit and what the discussions were and what the plans were. So it really helps the inpatient team find outpatient notes in one location. This is an example of one of our multidisciplinary outpatient notes. Now, this isn't the full note. I wanted it to be able to be read, and if I put the full note here, it would be way too difficult. But what you can see here is this additional recommendation or comments would be included in the visit note for the patient after the provider is done with their note. They would pull this in. So as you can see, what this stands for is the CSHCN, is the Center for Special Healthcare Needs. Our cystic fibrosis program at Christiana Care falls under a larger umbrella of the Center for Special Healthcare Needs, and so that's what that abbreviation stands for. But as you can see, this is myself as the advanced practice provider and what my note would be on this patient, the nutritionist and what their note would be and recommendations for this patient, as well as our physical therapist and their note and recommendation. This is not comprehensive because, as you can see, we are missing our respiratory therapist as well as our palliative care healthcare professional. Just that the note would have been way too small to read, but I wanted to give you an example of what it looks like when an inpatient or outpatient team goes to the chart to look at the visit note, and they can see the entire multidisciplinary note in one document. If anyone has any questions or comments, I will occasionally monitor the chat throughout the conference. So please contribute to this discussion there. Also, you can please connect with me on the networking platform, as I am happy to meet and discuss further. I have also included my email address here, and you are more than welcome to email me. I hope this has given you some idea of how we at Christiana Care have tried to tackle the communication and the care of our patients with cystic fibrosis between settings from inpatient to outpatient. Thank you so much for your time, and enjoy the rest of the conference.
Hi, my name is Kathleen Richards, and I'm a respiratory therapist. I work at Primary Children's Hospital in Salt Lake City, Utah. and I am the supervisor of the pulmonary function lab there. And I would like to thank Dawn and Carolina for inviting me to speak today at today's session on my project, continuing to bridge the gap between outpatient and inpatient CF respiratory care. I have no relationships to disclose related to this presentation. And the objectives for the presentation are to, you'll be able to state the aim for the development of this QI initiative, discuss barriers and challenges encountered, and then list ongoing efforts and change ideas for holding the gains. So before I actually start with some background information about this project, I also wanted to give a little bit of background. So we started our project in the fall of 2016, and then I presented this information at NACFC in 2017. Since then, we have had, ongoing, continuing efforts to bridge the gap. So I thought I'd start out giving some, again, background to the start of our project, and then move into the efforts post NACFC 2017 a little bit further in the presentation. So starting off, some background. So anecdotal feedback from CF patients and parents identified inconsistencies in the respiratory care that was being provided during a hospitalization between the inpatient respiratory therapist as compared to the outpatient respiratory therapist. So the outpatient respiratory therapist, we work in the pulmonary function lab. We attend the NACFC and the all-day airway clearance course that's provided the day before the conference actually fully starts. And so we are receiving that training every year, and then we are coming back and using that evidence-based CF Foundation approved respiratory care to instruct our patients and families in the outpatient setting. So our goals were to provide high quality, evidence-based, consistent respiratory care for our CF patients, regardless of setting, inpatient, outpatient, or in the home, and then also to improve patient and family satisfaction. So our methods were that inpatient and outpatient respiratory therapists collaborated on standardization of the various airway clearance techniques. We came up with a 22-item quiz that was developed to assess knowledge of the various airway clearance techniques. And those techniques were huff cough, active cycle of breathing technique, vest therapy, oscillating PEP, PEP, CPT for both babies and then also pediatric and adolescents. It also covered specifics regarding inhaled medications as far as the proper order of medications, proper nebulizers for each medication that is being administered, and then also it covered infection control guidelines. The quiz was administered to all inpatient and outpatient respiratory therapists prior to us then providing an educational in-service. The quiz was then re-administered within 30 days post in-service. This is just an excerpt of the 22 question quiz. And then ongoing continued methods were that we developed a cystic fibrosis RT reference sheet for our inpatient respiratory therapists. And the reason for that is that our hospital, and again, many other hospitals may be the same, is that the inpatient respiratory therapists have responsibilities not only for the care of patients on the floors, but also in the intensive care units. And that could mean the newborn intensive care unit, pediatric intensive care units. And so it may be weeks, maybe even a couple of months before some respiratory therapists are back on the floors caring for a CF patient when they're admitted. And so there may be nuances in the care, certain treatments that a patient's receiving that the inpatient respiratory therapist could then reference by having this sheet. So that was our goal with that. And then a champion was identified from the inpatient RT department that would attend the NACFC and the airway clearance training course along with the outpatient respiratory therapist so that they could provide ongoing education for the inpatient RTs. This here is just what the CFRT reference sheet looks like as well. So our results. 62 inpatient respiratory therapists attended the in-service and completed both the pre and post quiz. The average pre-in-service quiz score was 18.14 correct questions, and with a 82.4% range. The 5 most frequently missed questions on the pre-in-service quiz were regarding huff cough, order of inhaled medications, in particular when to administer the inhaled steroids, CPT positions, and then also a question on the regarding the metaneb. Of note, the most missed questions also correlated with the feedback that we had received from patients and families prior to initiation of the project. The average post-in-service quiz score was 19.69 or 89.5%. And we did a paired t-test and looked at the pre and post change of the overall scores, and those did reach significance. We also did a separate analysis of the 5 most frequently missed questions, and 3 of the 5 also reached significant in the differences. Inhaled medications and metaneb, those 2 missed questions did not show significantly differences. So we set out with education initiatives. We planned for ongoing education for the inpatient respiratory staff. An annual education day is held for them. And then the outpatient respiratory therapist goes and participates in all new inpatient RT's orientation. So we pretty much provide the bulk of the education regarding CF care to the new orientees. And then we also have the new inpatient respiratory therapists come over to observe the outpatient clinic visit. This gives them an opportunity to see what our patients and families are experiencing at a visit, and it also gives the inpatient RT an opportunity to see what our role, the outpatient RT, what our role is in the care of the patient and how that differs from them. We also developed airway clearance educational videos, and these educational videos, along with that 22 question survey quiz, was utilized to provide quarterly education. And I say that in that we have these quarterly education modules that are mandated throughout the hospital. And so what we did is we just had this particular module rolled out to all respiratory therapists annually. And this was just a great opportunity to provide re-instruction for all RT staff. That first year when we rolled that out, 74 of 84 respiratory therapists completed the module with an average score of 93%. So our conclusions were that standardization of CF respiratory care can be challenging, but it is paramount in order to achieve our goal of providing exceptional quality care and customer service. And with the rotation of inpatient respiratory staff and staff turnover, it really did reinforce the need for ongoing education. We plan for future initiatives, those being to revise and implement an airway clearance technique flowchart that inpatient respiratory therapists could reference when initiating the various airway clearance techniques when a patient is admitted, and then also when they were needing to maybe try a different technique. If maybe they're not able to mobilize as much mucus and many secretions, that they could go ahead and maybe try a different technique with that patient. And then the educational videos that were developed for staff, we wanted to make them available to patients and caregivers that they could access from home and then also when in clinic. And again, those was all part of our ongoing effort of making sure that the consistency in technique was being applied regardless of setting. So this is just a draft of the airway clearance technique flow sheet. And I do say it's a draft. because as you can see on the bottom right-hand corner, this was from September of 2017, with our thought being that post NACFC, we would be able to roll this out to the inpatient RTs. However, since this project initiated in the fall of 2016, to date, we now have a 5th CF respiratory floor coordinator. So not only has there been changes in staff, there's been changes in leadership roles for the CF leadership role for inpatient RTs. And so it is just made implementing this type of decision tree difficult. So as I mentioned, up till now, that was a project that I had presented in 2017. So now I'd like to kind of move forward. These are all change ideas that have happened since post NACFC 2017. So as mentioned, the airway clearance technique educational videos that were developed for staff, we wanted to make available for patients and caregivers. The inpatient respiratory department, along with the child life department, developed an incentive program for CF patients to earn prizes for well-performed treatment participation. And then outpatient and inpatient respiratory therapists joined the weekly inpatient rounds starting December of 2019 in an effort to standardize communication for the respiratory care that was being provided for CF inpatients. So just a little bit more on the educational videos that were developed. They were developed for, there were 5 of them, huff cough on active cycle of breathing, aerobica, and then CPT for both babies, and then also pediatric and adolescents. So we needed to develop or find a way to make sure that we could share that information with our parents and the families. So in 2018, the spring of 2018, we rolled out a Primary Children's Hospital CF webpage. And so then we went ahead and embedded the video links into that webpage for families to be able to access. We also worked with our IT department and also the foundation, our hospital foundation, to acquire iPads that could be in each of the CF clinic rooms. We know that those clinic visits can be long, and so this was a way for patients and parents to be able to access the educational videos during any downtime in a clinic visit. And so I just thought I'd go ahead and just give show a small excerpt of some of the videos. And that was huff cough, and now I'd like to show you one on CPT for babies. I selected these two because these were, again, some of the areas of concern by our patients and families that were expressed as far as inconsistencies in technique between RTs. All right. So again, just a little portion of what the videos look like for staff and for patients and families. So here is some information regarding the Inpatient Incentive Program. So our inpatient RTs, as mentioned, worked with the Child Life Department to develop this program and then also to help acquire the prizes for the treatment participation. The inpatient RT leadership met with our Parent Advisory Council to discuss the concept and to get their buy-in. And then they also developed criteria for what would be deemed a successful therapy treatment session. As mentioned, prizes were then acquired by the Child Life Department, and then the respiratory therapist also developed a My Treatment book so that they could track the treatment sessions. This is just a kind of what that treatment booklet looks like, that each family or each patient that participates in the program is given. So, update on that program. So our Parent Advisory Council approved the project in May of 2019, and then they initiated the program in the fall of 2019. So in that time between May and the fall, they went ahead and they set up the criteria and developed that treatment booklet. So to date, from initiation until March of 2020, 15 patients have participated in the program. Once the pandemic occurred, we've seen quite the decrease in the number of CF admissions, and no patients at this point have agreed to participate in the program. But again, we've had very few actual CF admissions since March. So our inpatient, weekly inpatient rounds, they had been attended or were being attended by inpatient hospitalists, the on-call physician for pulmonology, and then also nursing, social work, dietitians, and pharmacists all attended the weekly inpatient rounds. So in December of 2019, both outpatient and inpatient RTs joined those rounds, in an effort to, again, standardize the communication regarding the respiratory care for those inpatients. Again, with the pandemic occurring in March, the suspension of inpatient rounds occurred, and they did resume virtually in June. However, there aren't very few admissions, and so they are very sporadic and occur just when there is a CF that is been admitted to the hospital. So again, we set forth future initiatives. So we are going to begin, as a matter of fact, at the end of this month, we're going to begin monthly meetings between the outpatient respiratory therapist, the inpatient RT CF leadership, and then also the CF Center inpatient coordinator. That person, our inpatient coordinator, visits with the patients Monday through Friday, and does seem to get feedback from families on any issues or concerns. So we thought it was important for her to attend our meetings and be able to share any feedback from families where we can maybe find improvement and make some change ideas and address any concerns by the families. We also plan to revise and implement the airway clearance technique flowchart for our inpatient RTs. So it's not something we're giving up on. We have a new floor coordinator on the inpatient side. He started in May of this year. And so our plan with being able to start having these monthly meetings is that we're hoping that we'll be able to, again, revise and then make decisions and efforts to roll that out. Again, within the pandemic, not sure what that time frame looks like, but again, we're not giving up on this initiative. So thank you very much for inviting me to speak, and I'm happy to take any questions and also happy to share any materials as well. So thank you.
Thank you, Dawn and Carolyn, for having me. My name's Perdita Shook, and I'll be discussing how to bridge the gap between knowledge and action. I do not have any disclosures. And I wanted to remind everybody that there is a chat box associated with our discussions today, and I'll be monitoring it periodically throughout the month. The objectives today are our main focus is removing the disparities between inpatient and outpatient care, how to improve communication, education of bedside providers, continuity of care, and improving patient-family caregiver satisfaction. I currently am employed by Cook Children's Medical Center in Fort Worth, Texas, 443 beds and over 120 RTs. I want to say it's over 130, but I went with the safe number. This is just the original part of the hospital that was opened in 1989. I started in 2003 on a winter plan that most hospitals in our area do. Excuse me. This is a Lego model of the entire campus in one of our rooms for the kids to come enjoy. This is the original building. So in 2017, my director, along with a manager, decided that we needed somebody that would be a go-between for our CFs that were inpatient and for somebody that can communicate with the clinic and with the physicians. This came about because of one mother in particular wrote our CEO a letter, and he wanted us to address it. So thus the creation of my role. It's a role, not a job description. We haven't moved on to that yet. So I was given a blank slate, so to speak, and was told to here, go and do. And so I started by getting myself plugged in. You can ask our CF coordinators, Janet and Carrie Stradley. I know many of you know her. I would just say to them, hey, is this meeting something that you think would benefit the inpatient CF or benefit me, or is there any input I could put into this meeting? And so I started joining their meetings. I also spent a lot of time with the respiratory therapists. The CF clinic has 5 respiratory therapists. They're shared with all the providers. So they not only do cystic fibrosis care, they also do the asthma, the neuromuscular diseases, and everything else that walks in the door of a pulmonologist. So I spent time over there with them and let them teach me what I thought I knew. I had to relearn some things. And then also started attending meetings. I found it hard at first. I did not understand QI. I mean, I graduated in 1987. We didn't even have computers. So QI, I've heard of it. I just didn't understand the lingo. So I bought the book that was recommended, and I started going to the QI meetings. And so I've learned a lot in that respect, and I can share that back with our staff. Finding desk space, in a hospital is never easy. I actually ended up in the corner of the supervisor's office. I think I have a picture of that. And that's where I work. I also try not to spend a lot of time there. I like to get out to the hospital and visit with our inpatients, or if I know a particular patient that had just been in the hospital is coming back for a hospital follow-up in the clinic, then I like to go over and say hi. I think it's important that they know that we really do care about them and about who they are, and not just about their disease state. I think part of this role is creating relationships and going through the good times and the hard times. And our hospital employs Child Life, and I use them a lot. I rely on them, especially if they don't understand something that's going on, or how can I explain this better, or they'll go in and actually do it for me. All right, improving communication, one of the first objectives. I already spoke to spending time with the pulmonary RTs. And you don't know what you don't know until you know what you never knew, sort of. In spending time with them, I realized that what we were saying as respiratory therapists to the inpatient CF population was different than what they were hearing in clinic. An example would be if they asked our advice about cleaning their in-home nebulizers, I guarantee we would say the vinegar and water, because that's the last known for asthmatics that I knew about. I've never given that advice to a CF patient, but if somebody asked, and I do know that they get their education yearly over in the clinic, but it sure is nice to expand upon it. Or we spend so much time with them in the hospital when they're doing their treatments that I use that time to educate and to actually find out what they know or what they've retained from everything they've been taught in the clinic. Also, ways to improve communication are attending and participating in the clinics, of course, QI meetings and their projects. And I bring that information back to leadership. It helps me speak to goals, and then I can in turn turn around and get that out to the staff. Once a week, I believe ours is on Friday, I attend via Zoom the interdisciplinary meeting where all disciplines come together. They do discuss the inpatients and then go over next week's clinic list. And so that I gather information that's important for us as a respiratory department, because if they have a possible admission for Wednesday, and Wednesday we think we might have too much staff, that does happen occasionally. And they're like, well, we're right on the edge, but I'm going to send so-and-so home. And I'll be like, but we're going to have a CF admission. Sometimes that'll change the way that they do the staffing for the respiratory care department, because they know that we'll be having a CF coming in. Also, a project is the inpatient PFTs. When our CF needs a PFT, they are taken across to the Dotson Center, which is attached to the hospital, but we take them, we have tunnels specifically. Tunnels just sound so dark, doesn't it? Hallways, a basement that gets over there and goes up the staff elevator, and they go in through the back door to the negative pressure room for a PFT. They do all their outpatient PFTs in the same PFT machine, and they also do their inpatients. To me, they're on the same machine versus the machine of the hospital, so I think it's better consistency. But the communication from the floor, RN, the charge nurse, the physical therapist, the respiratory therapist, and then getting over to the clinic in a timely manner. Actually, we started a QI project on that, and it got put on hold because of COVID. So when COVID is lifted and we can start these projects again, that'll be one hopefully I can share next year. We have two medical directors. We have the medical director of the pulmonary clinic, and then a medical director for respiratory therapy. Once a month, the medical director comes to the respiratory leadership meetings, and I catch everybody up there. And, I have the opportunity to ask, where would you like me to take this? Or what would you like me to focus on for this month? He gives his input or agrees with what we were working on at the time. Let's see. So, education of bedside providers. I chose a teddy bear because we are a pediatric facility. So I now assist with all new hire orientations. I do their CF education. I put a little PowerPoint together and just go over, because, I start with what we learn in school. Everybody knows how to give a nebulizer. Everybody knows how to do a vest, generally nowadays when they come out of school. But what are the differences, and how do we apply that to our cystic fibrosis patient? Making sure they understand exactly what CF is and what the families are watching for. We're not just the adult patient. We have moms, dads, aunts, uncles, brothers, sisters, older brothers or older sisters that will stay in the room, and they take turns, so that a lot of times they're not there by themselves, but they have been taught about germs and hand sanitation and standing 6 feet apart. They've been taught that from the beginning. So when you go in and you're in your full PPE, gown, mask, goggles, your gloves, and you reach in your pocket and pull out your treatment sheet, and laid it on their computer and then put it back in your pocket, you're just sharing germs from space to space. And they do comment on that. They comment on a lot of little things. I do go and check on them, and they will ask, well, what about this or what about that? So they're always watching, and we don't take that as a negativity, take that as a positive, to make sure that we are in check ourselves with what we say we're going to do. Our department has a monthly newsletter that goes out called Reflections, and I do put in reminders into Reflections or education. Like with COVID, I was putting the COVID numbers for CF in at the beginning. I attend all the staff meetings where I can share anything we need to, that needs to go out to staff. And there's always email. Sometimes it's the simple things like when we get a patient in and they're getting a specialized medication and a specialized nebulizer, that's a different charge for our facility. That's a different charge probably for everybody. And so I'll hang up that reminder sign in the computers downstairs in our department, just as a reminder, if you're charting this, to go ahead and click this box versus this box for charges. It's just little things, and it helps everything be nice and smooth. Policy and procedures once every quarter, any policies relating to that would involve a cystic fibrosis patient. I always make sure that they cover the cystic fibrosis population. And like nebulizers, we rinse with sterile water. Also make sure that we're doing CF Foundation guidelines. And trying to think what else. I think that's it. Now on the therapy list, because I witnessed, and I probably did it myself back in the day, back when I didn't know any better, pulled my list out of therapy because, you know, cystic fibrosis patients get multiple medications, especially their morning treatment and their last treatment of the day at night before they go to bed. So I now write the therapy down if they're Q4 or 4 times a day. And some of our CF patients get up at 7, some don't get up till 9:30, and that's you trying to get them up. So I'll provide a therapy list. At 8 o'clock, we're giving these medications, and I just put them in order, in the order that they go with their VEST settings. And then the second treatment of the day, the third treatment of the day, and the fourth treatment of the day. What exactly, so you don't have to pull your list out. It's laminated, so it can be hung in the room because it can be wiped down. There's also a copy down in a book for CF down in our department, where the therapist can look ahead of time and see. And there'll be little notes on there like, mom prefers if the nebulizer is air dried on the top shelf. We do have a family that comes in that prefers that. We have a young child that comes in that wants to do the wrap when they come into the hospital. Just the little piece that wraps around for the, to do the vest therapy. And mom's like, no, if I'm not here, they need to do a full vest garment. So those little things help the respiratory therapists when they're in the room. So they're not getting one pulled over on them, as I say. The physicians have even gotten to the point when they change an order, I will see it because it pops up on my screen, but they'll text me and tell me I need to change my sign in the room. And that always makes me smile. Also, I like to check in with the patient's nurse and see if there's anything I need to know about, or the respiratory therapist. The respiratory therapists carry the ones that carry the CF populations also may have PRNs, BIDs, other things, other patients on their list. And so especially that morning treatment or that first treatment of the shift that's the longest, I'll go up and make sure that they're okay. If they get called for a PRN, technically they'd have to stop and then go do the PRN and then come back. Or they'll call me and I'll go up and stand in the room and finish out the therapy so that they can go on and take care of that PRN that probably really needs them. The nurse, sometimes they might have heard from the physician the day before that there might be a PFT today, though nothing is written down. So we'll then make sure that everything is set up in order to be sure that they can get to their PFT on time. Continuity of care. Teamwork makes the dream work. I know that may be overused, but it really does fit with the theme of what we're doing, trying to bridge this gap. Knowledge, we had the knowledge, I don't know it was the correct knowledge, but now that I have the correct knowledge and we passed it on, the period of action starts. And one example would be the QI vest fit project that we did. My favorite line is, just because it closes doesn't mean your vest garment fits properly. I noticed a 17-year-old, very tall, very thin CF patient stood up on the side, he was on the other side of the bed, and he put this small small child, I think it was a small child vest on, closed it, sat down and hooked up his vest machine, his vest therapy machine. And I think the vest blew up like a ½ inch, and that's it. And I was like, whoa, what's going on? So we measured, and he actually belonged in an adult large by his chest measurement. And so that was eye-opening. Took it back to the QI, and we did the vest fit project. So pediatrics grow. So one thing I wasn't aware of is just because the garment they bring from home and they want to use in the hospital may not really fit them properly. And so I've stressed measuring of the CF on admission, the CF patient on admission, and making sure that the vest you either get out of the disposables, garments that they get clean disposable garment, or they bring theirs from home and it may say adult small and now they need an adult medium. Also teamwork with the clinic is, I asked them, how are your hoses on your vest machine? And they're like, oh, I got them duct taped. So I can just send an email over to the clinic and they can get hoses ordered, and then it's in their clinic chart. So whenever there's a question, they can just look it up right away. I think that I can chart it on my side. We use Epic at Cook Children's, and I have the ability to see the clinic's side of charting. And I sometimes reference it if they come in saying, oh, my vest settings are 8/6. I can go in and look and be like, it looks like they have you at 14/10 or 14/9. And so that way we know we're not getting a fast one pulled on us. So I walk over to the clinic a lot. The coordinators at their desk, the doctors are there, the respiratory therapists are there. So we use Skype in our facility. So if I have a quick question, if a patient says, why am I still doing Q4 albuterol at night? I don't think it really helps me anymore. I needed it when I first got here. I've been here 7 days. I can quickly Skype that over to the CF coordinators and ask the physician and get an answer pretty quick. So sleep is important. We know that from the studies in this in CFs, and that they do suffer from sleep. So if it's one less thing, and they always have a PRN order. So I always tell them, if you wake up at 3 o'clock in the morning and you need a treatment call, somebody will be here and give it to you. And I already discussed the ability to see the clinic's charting in Epic. Improving patient, family, caregiver satisfaction. This is huge for Cook Children's. We we're in the chat, Children's Hospitals Association of Texas, and we have to maintain as a hospital our satisfaction scores higher than chat's average, which is usually 86, 88, and we're, I believe, a percent, and we're up, or we have to be up around 93 to 95, and I'm just pulling numbers from the last time that I saw this. So one of the big initiatives in starting my role was improving patient family care satisfaction. You know, from if you are a clinic RT, you work in a pulmonary clinic, every CF has a very specific way they want to do their therapy. You know, we all brush our teeth, we do it a little bit differently, but we get the job done. And the same as if they're doing it correctly and in the correct order, but they may, little things, the way they sit or where they stand, or some want to wait till the vest finishes completely before they start. You know, they'll do their albuterol, then do the vest, then start the rest of their medications. Some want to do everything they can on the vest, but of course, you know, teaching the reason why we don't do our antibiotic breathing treatments, anti-infectives, while they're doing the vest treatment, explaining that to staff, passing that information on. And so our families are a lot happier. They know that I'm going to come check on them at least every other day. Some of them need it more often. And I feel like they can say, hey, how come this? And we can just fix it on the spot if it's something simple. And most of the times it really is. I like my nebulizers to air dry on the top shelf. They feel it's cleaner there, away from, and this is not near a sink. So little things like that, whatever helps make their stay better from them. Some of them have very complicated vest machine settings. They want to change every 5 minutes. So I'll usually go program those in for them so that it just automatically does it. And they don't have to explain to every therapist that walks in the room how to do it, or now it's time to change to this, now it's time to change to that one. I joined the faculty advisory committee for CF. It meets on a Monday night every month, but July and December, and we come alongside them, and they, the families, share what would work best for them while they're hospitalized. I think we worked on an admission kit, like where they can get a little activity every day brought in. The most recent one was the I say recent, it's probably pre-COVID, was a towel that's embroidered with the word breathe. It's a really thick white towel. The towels in hospitals are notoriously small and rough. And so if you're going to be there for 14 plus days, we like to give them a towel. And then part of what Cooks also does is, if we have met our patient satisfaction, family satisfaction survey results, then at the end of the year, we get what's called a share care. And it's a portion, we are a non-for-profit, so we get this dispensed to us. Some of us call it bonuses, but they're really share cares, or care share. Now I have to go back and figure out which one that is. Party of one, bridging the gap between knowledge and action. So if they need me to staff, I staff. If there's CFs, and then I will take them. Sometimes I'm needed to just take a whole floor assignment. You know how staffing runs in a hospital. I'm not fully a bedside RT as far as taking an assignment every day, but I'm not total leadership management either. So I get caught sometimes being left out of stuff like emails or whatever. And so I always just say, I'm a party of one. And that always gets a little bit of giggles. But I think a party of one in this case really helps to bridge that gap between knowledge and action. I think that it has really made a difference in our patient population and in our, I know that the CF coordinators have said as much. So thank you, everybody, and that'll end our discussion.
So as you can see from these presentations, there's been an increased awareness over the years to the need to bridge the gap between outpatient and inpatient CF care. From this awareness, great work is being done, and we are hopefully narrowing that gap. Carolina and I would like to thank the speakers of this discipline group session. We chartered new waters with an on-demand session for the conference this year, and the speakers rose to the challenge. If you have any questions for our speakers, please use the chat box and/or the networking platform. The chat box will be occasionally monitored throughout the conference, so please consider contributing to the discussion there. Thanks to all of the participants in this session. We look forward to seeing everyone next year in San Antonio, Texas. Thank you.
Thank you.